I presented this challenging case a few weeks back, and most of the comments were spot on that it's a case of total hyphema or 8-ball hyphema. Now, this child had a history of a blunt trauma to the eyeball with a tennis ball 2 days back, and now he presented to me with a painful decrease of vision. You can see even on torch that the eye is full of blood. Blood in the anterior chamber is called hyphema and can be diagnosed with slit lamp examination, but if the whole anterior chamber is filled with blood, then it can be diagnosed even with a naked eye or torch examination. So it is a case of total hyphema or 8-ball hyphema. Now, the most common cause, as in this case, is a trauma. It can also occur after intraocular surgery, especially after trabeculectomy, small incision cataract surgery with iris damage, iris ciliary body tumors, new vascularization in the anterior chamber, juvenile xanthogranulomas, uveitis glaucoma, hyphema, UGH syndrome after ACIOL, blood disorders, dyscrasias, and the use of anticoagulants. So if the hyphema is bright red in color, it means that it is fresh and it is called total hyphema. If the color is black, it means that the hyphema is few days old with impaired aqueous circulation and decreased oxygenation of the blood with raised intraocular pressure, and then it is called 8-ball hyphema. And when it reaches that stage, it needs urgent evacuation. If the blood remains there in the anterior chamber for long, it causes corneal staining. So the causes for surgical evacuation are hyphema that is not responding to the full medical therapy, that is not decreasing in size, hyphema in which the IOP is constantly raising or high, when the corneal staining start to occur and hyphema is there. If the patient has a sickle cell disease, even 1/3 hyphema is dangerous because of sickling episode. So all these are the indications of the surgical evacuation. Total hyphema can cause decrease of vision by obstructing the visual aqueous, block of trabecular meshwork, pupil block, posterior synex, peripheral anterior synex, all causing raised intraocular pressure, corneal staining, amblyopia in a very small child, and rebleeding when initial clot retracts and lyses. Rebleeding is more severe and most common within the first 4 days after the first bleed. So total bed rest and 30 to 45 degree head elevation is done to allow the hyphema to settle inferiorly. Medical treatment is topical steroids, cycloplegics, and anti-glaucoma drugs. Carbonic anhydrase inhibitors are given when sickle disease is ruled out. If hyphema not responding to medical therapy, then surgical evacuation with anterior chamber irrigation aspiration with paracentesis is done. For pupillary block, PI is indicated in full hyphema. Sometimes a trab is also required in future, so close follow-up is necessary. Thank you.